have ATN, you do supportive treatment. You identify what is the cause of ATN, because like remember, ATN is like you're telling me he has a fever. Fever from what? Is this an infectious or non-infectious or malignancy, or what is it? ATN, you need to further investigate why this patient has an ATN. And once you identify that, the treatment is supportive. And one of the very important aspects of treating patients with ATN is do not overload them, especially if they're oliguric. Some patients, ATN can be oliguric or non-oliguric. If you have a non-oliguric patient, you kind of relax. I don't care about the number. I don't really care about the number if you're peeing. But if you're not peeing, that's a problem. Because at one point, you're still getting your antibiotics, you're still getting your regular eyes and nose every day. And at one point, we're going to reach a point where you're going to be like overloaded. And you need to take action. And we're going to talk about that in a minute. But that's the teaching point, is supportive. Okay? So, let me just go down really quick. Why don't you help me read, Anthony, the next one? Do you read the...
On day 6, after surgery, the patient's BMI is 68, creatinine is 4.1. His urinary volumes are between 300 to 500 a day. Serum electrolytes are sodium is 142, K is 4.2, chloride 98, bicarbs 23. The patient is started on fluid and salt restriction, but he remains oliguric. By day 8, the patient's BMI is 85, creatinine is 6.3.
So, do you need to dialyze this patient, Anthony?
I think so.
Why? Why are you going to dialyze him? Dialysis is invasive, right?
Yeah, this is pretty bad. Uremia.
Is he uremic?
At this point, right?
What are the symptoms of uremia? I didn't tell you he was altered, did I?
What's that?
I didn't tell you he was altered.
I'm sure it will be.
What are the signs of uremia? Do you guys remember what are the signs of uremia? Mentation,
Itchy skin.
Yeah, you can get like a uremic frost, but that's when the BUN is like probably 300. You can get tremors, you can get seizures, you can get altered mental status, confusion, but there's really not such a thing as a number defining that. Like, it's different for everyone. I've seen patients with BUN of 170 talking to me, and I've seen patients with very acute rises in the BUN being very altered. So that's why you can't really send these patients out, because his creatinine is still uptrending, his BUN is still uptrending, his urine output is not the greatest, he's not completely anuric, he's oliguric, but it's not the greatest to send him out. But you need to do a daily assessment for dialysis need. So you look at the patient, you talk to the patient, you look at the volume status, you look at the eyes and nose, you look at the electrolytes. So recently we reviewed the indications for dialysis. She mentioned them all. So his labs are okay. Look at the sodium, potassium, bicarb is okay. He's not altered, he's not overloaded, he's breathing fine in room air. So we want to wait. And like I was saying, like if the patient has like still urinates, you still have more room. If the patient does not urinate, or let's say that sometimes, like this question about like when to do dialysis, they've done studies like early dialysis versus late dialysis. That's a question that is unsettled in the critical care nephrology literature, but it's up to your clinical judgment. Like if I get invited to a case, like the ICU attending calls me, and the patient is going down like this, like MOD, multi-organ dysfunction syndrome, like everything is failing. You know that you're not going to get away without dialysis. You know that. So you need to, probably at that point it's better to put a line before the patient is coagulopathic, because these patients with multi-organ syndrome, they become, they have respiratory failure, they have failure of the, altered mental status, they need to get intubated, they need to get fed with a tube, and they become very coagulopathic. So you need to make the decision, like a decision when to put a line and to have it ready for dialysis. But a patient like this, he's in the ward, he's in the regular medicine floor, he's probably in telemetry. He's fine. You just go there and you talk to him every day. How are you doing? You're breathing okay. You tell him, like we hope that the kidneys are going to turn around, but they're not turning around just yet. Like I'm going to ask you for some patience because I cannot send you home just yet. And you're going to have a case manager telling you, like, when are you going to discharge the patient, Dr. So-and-so? And you're going to tell her, the patient is not ready yet, thank you. Yeah, the case managers are going to be behind your back, like asking you to discharge the patient. But just make sure you know that this guy is not ready yet. Okay. All right. Go ahead with the next paragraph, James.
On day 9, postoperatively, the patient's urine output begins to rise to 1 liter per day, and by day 11, it's up to 3.5 liters per day. Patient's BUN is up to 92 milligrams per deciliter. Creatinine is 6.9 milligrams per deciliter on day 11.
Okay. So he's peeing a lot, right? Is that a good thing or a bad thing? Yeah. When you're doing your nephrology rotation, you're in the business of making urine. If patients are making urine, you're happy. So you're very happy, unless they